Welcome to Care Transitions Today, Case by Case, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we take a fresh look at the real-world challenges of case management related to care coordination, patient transitions, utilization management, and complex discharge planning. Today, we are joined by Dr. Rebecca Severe and Dr. Sweta Singh, along with special guests Dr. John Eanes and Kimberly Browne. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Kimberly Browne is the Executive Director of Social Work and Patient and Family Services at Lucile Packard Children's Hospital in Stanford. Dr. John Eanes is the Medical Director for Utilization Management and Case Management at Children's Healthcare of Atlanta. Whether you're a physician, case manager, or leader in case management, this season provides valuable insights to navigate complex patient transitions. This is Care Transitions Today, Case by Case. Let's begin the discussion with our first case.
Hi team, I have a PEDS case for us today. So I have this little kid, 4 years, 2-month-old female with a history of sickle cell disease complicated by recurrent acute chest syndrome, elevated TCD velocity, and sickle cell cerebral vasculopathy with mild to moderate stenosis of the left ICA, central access for chronic red cell transfusion for primary stroke prophylaxis, presenting with fever and cough. So this kid has a poor immunity to begin with and has a central line and high risk of having any infection make it an acute chest syndrome. So this kid gets admitted and they get the blood cultures, they send the workup and admit the kid to the ICU for monitoring. With her sickle cell disease and history of acute chest syndrome, acute chest is also on the differential. And also they are worried about central line sepsis, so with possibility of bacteremia. So was started on IV ceftriaxone, azithromycin, and blood culture is drawn. And this patient is getting admitted. Now, what would you like this patient class to be when admitting this patient?
This becomes such a complex issue because, truthfully, for a lot of these kids, you talk about a lot of rule outs. But in perspective, a lot of these kids, you don't necessarily find anything. Many times when they come in, you're going to see, you're worried about the significant severity you may encounter, but many of them start off doing relatively well or may have some initial symptoms. And then you just have to wait and see how they do. And that's where you end up in a difficulty trying to decide an initial status, because it's very much probable in your case that you may see them get better and cultures are negative and you discharge them very quickly. And equally, you have a small percentage that actually get sick relatively quickly and deteriorate just as fast.
Yeah, I think. Go ahead, Rebecca.
I was just going to say, I think, Dr. Eanes, you make a lot of great points, because I think that's where my head was going too. It's hard. This kid has all the potential in the world to get sick, get really sick. So for me, I think if I were making that decision on the status to start with, it would be, how many objective points do I have to say this kid is about to get sick? And if it's more, all the risk factors, but the blood pressure's fine, the labs don't look too bad, SATs, all of that, then I would probably be I'd probably say OBS to start with. That's, I guess, how I would kind of tease it out for me.
We decided to start off with inpatient primarily because of the fever, and during that time, of course, they're tachycardic and looking sick, and especially given the complex history and risk factors. Fair enough, as the time progresses, like you guys shared, 48 hours, blood cultures are still negative, and the RPAN, our viral panel, came back positive for para-influenza and human rhinoenterovirus. So this kid was stabilized, monitored, and then stopped the antibiotics and discharged after 48 hours of the admission. So overall length of stay from ED arrival to discharge is less than 60 hours. So if this...
Really? Oh, excuse me. This is where you really see the difference in how kind of the payers look at it too. And you'd said you'd admitted to the ICU. And the same perspective in the children's hospital we had, a lot of these kids would come into the floor. But it makes a big difference from your reimbursement, because for the ICU, your losses can be much more significant versus the floor. At the same time, the determination equally shouldn't make a difference. Your care is going to be the same whether you're on the ICM floor or just closer monitoring. But you also encounter an issue that we see frequently with the kids is they'll come in with a fever, they'll come in with significant tachypnea, tachycardia. They may look bad because of the fever itself. And so you have this you drop the fever, they look great. They're running around the room and no problems. And it's a very hard thing to kind of predict, even from a provider standpoint. These kids will look horrible, and you're like, oh, he's going to pass away. But in reality, if you just give him a little bit of time, give a little bit of fluid and stuff, you'll do well. It's a hard, complex issue to address. And so what you more often find in a lot of these is you're looking, not only you're trying to predict whether you're going to stay more than that 48 hours to make the inpatient. But at the same time, you've got to take into consideration all the services you're providing. And what ends up happening for many of these kids is it ends up in a little bit of a negotiation, not only with what you think may happen, but also what you've contractually agreed to. That some of these kids, you may need to contractually agree that they have to be in an inpatient status to start with, because the amount of services you're providing, not necessarily in the anticipation that all of them are going to be sick, but you've got this complex kid coming in that you anticipate is going to need a lot of services needed to be monitored closely before they're discharged.
I think I didn't add another important information, because I looked at this case more retrospectively. When initially looking at the chart, okay, they're worried about the acute chest and the central line has a port, and that can lead to sepsis. Those are the things which another kid coming in with fever versus this kid coming in with fever. What made it more complex, or the reason for ICU level monitoring initially, was this baby also has a history of asthma and was having respiratory concerns. And even if they're having viral illness, but they do have initially pretty bad sounding lungs and wheezing, and they're getting Decadron for that along with the inhalers. So that's why I think I like that idea of having a contracting be involved in these cases up front when we are talking to the payers, to make that discussion, hey, it's not something that's your bread and butter asthma exacerbation patient or acute sickle cell patient. It's a combination of everything that's adding to the complexity and the intensity of care.
Yeah, I definitely think that this is one I would try, and I would try to, highlight all the points, and really just I liked how you phrased it, Sweta, about this is not just your bread and butter asthma, or even, bread and butter sickle. Like your multiple high risk situations coming together, and obviously with them putting him in the ICU and doing what they did, I think the physicians demonstrated that they had a high level of concern that this child was going to decompensate. And so I would play off of those factors and really try to hone in on those in a peer-to-peer. But I also, just given the short stay, know that this would probably be a harder case to win. So.
And you comment, because the retrospective scope, it's always, we always, when the determinations are made, it should be what was seen at the time of admission. But at the same time, for a lot of these kids, the realization is they get better quickly. Even when you talk about the third party references a lot of people use, they disagree on what would, because you've got a whole list of items that you would look at with those third party references. And one will say you should be inpatient, one will say observation. And unfortunately, it's a little bit of the witch doctor trying to guess who's going to stay the long time and really require the services versus who's going to get better quickly and be able to go home.
Those are very good points. I think, Kimberly, you have a next case for us.
Yeah, thank you. I was going to share with you all just kind of a look back at one of the challenges that comes up pretty commonly, sadly, when we have patients who are in need of psychiatric intervention and have really complex medical needs. A lot of the patient population we see in this setting are patients who have chronic medical conditions. This particular patient is a 16-year-old female with inherited disorder of cholestasis. We know that the prevalence of mental health condition in our teens who have chronic physical conditions is significantly higher than those without. Greater than 51% of our kiddos who have chronic conditions present also with anxiety, depression, other issues along those lines. So unfortunately, in this instance, our patient had a lot of back and forth from our ED, a lot of just chronic medical complications, and subsequently, or throughout that experience, showed increasing signs of depression related to having to come to the hospital as frequently as she was. That sort of culminated in an event where she overdosed on Tylenol, had a lot of really messy medical needs associated with stabilizing after that intervention, given the impact on her liver. So she spent, I think, 4 nights in our ICU, then was transferred to a regular medical surgical floor once she had stabilized from a medical perspective, was held under, I'm in California, it's a 5150, in need of inpatient psychiatric hospitalization, and spent about 7 nights waiting for that inpatient psych bed. I think nationally there's just a paucity of inpatient psychiatric beds for adolescents. That's very much the case in this region. In our immediate area, we have one hospital that has 133 total beds for adults and adolescents. The next closest to us has 21 adolescent beds and 14 pediatric, but not a lot of options in our immediate surrounding area for sure. So it winds up that we often have to kind of barter with families to engage them in an openness to refer out to far greater distances for their kids to get the care that they need as timely as we want them to be getting it. A lot of factors come into play with that. I think one of the things that always feels concerning from my perspective in pediatrics is we're never treating just that child, right? We have all of the family dynamics that come into play. So in this particular patient's scenario, there was also a 13-year-old brother who was really trying to make sense of this huge experience that his big sister had just had, and all eyes kind of on her from both his parents' perspective. So really applauded our child life specialists in engaging the brother and helping him make sense of why his sister needed so much of the family's attention and support, and readying him for the fact that one of his parents was going to have to relocate out of the area temporarily to travel to the accepting facility with his sister once we finally secured placement. So a lot of dynamics really coming into play there, psychosocially, as well as sort of from a securing of placement and covering that stay during the acute hospitalization prior to transfer.
So Kimberly, just to clarify, so at least at some point, especially when that patient got out of the ICU and the medical issues were more stable, were you facing that, like what we tend to call a partial denial for that ongoing hospital level of care and needing to justify that to the payer?
That's right. That's right. We had that sort of middle chunk of really 6 days wound up initially being denied as medically stable. However, we were able to appeal that denial because there was no safe disposition for that patient. She needed the inpatient psychiatric, was not at a place where her safety was assessed to be such that she could return home with family until they could get her out of the community into a treatment plan. So we were able to successfully appeal that denial.
Yeah, and I know sometimes when you have, maybe it's not a psychiatric placement, but some other placement issue, whether it's maybe LTAC or sometimes, a rehab or something like that, where you're waiting for a while and it's on the insurance side of things. Did you have to, for this case or similar cases like this, have you had to go down the pathway of having to argue sometimes administrative days or custodial days or something like that, where you don't actually get hospital payment, but you get something else? And I don't know, Dr. Eanes, too, maybe you've had experience with this on these complicated cases and how you would recommend managing that when you get these kind of in-between denials.
This becomes a very regular problem for us. And a lot of it has to do with the fact that you've got these medically complex kids. The behavioral health, just in general, is under an enormous amount of stress. And that's just for kids that don't have other associated medical problems. But when you start adding diabetes and cholestasis and any number of other medical conditions, related to injuries to the child or otherwise. We've had children who've jumped off buildings, and you're talking about multiple orthopedic stuff. The psychiatric facilities had enough trouble just handling those kids that didn't have that and have no way to take care of them from a rehab or a recovery or take care of their specialty needs. So I'm seeing, at least in our facility, a lot more kids that will sit for a prolonged period for services for medical, and we have to provide psychiatric services on top of that. And we're arguing, hey, look, we can't transfer them. There is nowhere. We don't have LTACs. We don't have all these long-term facilities that can provide the services these kids need. Particularly as we're getting better and better at handling a lot of these kids that we've never seen before, that used to pass away from their illnesses. We're able to maintain them. And then we're seeing all the comorbid conditions associated, including all the psychiatric issues. I think our biggest thing that we've actually seen in our facility is we've had a tendency to document who have we tried each day, who we've got outstanding. And many times those notes help us more with the denials than anything else. We just have nowhere to go. Neither the payer nor us can find a location for these kids that will accept them.
Yeah, and I think that's a good point too, is just bringing up sometimes the details of the efforts the care management team has gone through to place this patient somewhere. We've had 53 denials. Like sometimes they when you say, oh yeah, we've had a lot of denials, like you need to be really, specific about where you've referred. We've referred out, in how many mile radius or how many denials. I think sometimes I found that to be really helpful, those details of what we've had to do to try to place this patient.
It's been more than one payer I've commented on the whole list, gone down 20 or 30 that we've called, and it's like, where would you like me to send them?
Yeah. A
lot of times we'll engage the complex case manager from the payer in the team meetings also to be able to kind of have that
sort of inside substantiation of the level of effort that we're putting forth to be able to secure a plan. So that has proven beneficial as well.
We've also gotten good at talking to the paramedical directors up front. So as we see those kids that are having difficulties, hey, look, we've got a kid and we don't have anywhere to send them. What would you like us to do? Or are you aware of this kid? What's going on? And it's truthfully become a two-way street in some respects, because even recently I've had them call me about kids that they're trying to find a location to go to.
I think that makes a very good point, especially we've run into that too, being proactive. Like we do get a lot of referrals from out of state, kids with complex medical need coming, and then it gets a little bit challenging because if they have out of state Medicaid, then we are already working on the single case agreement to take care of them as they're not part of the contract. But during that time, we recently had a meeting for a complex patient where it was part of the discussion. What is the final disposition plan and support? Because if this kid gets a new heart as part of the heart transplant, that itself adds the complexity that not just like disposition home is going to be that easy. The transition is going to be a lot more complex. So what do we anticipate? And being upfront and preparing ahead helps before we go into all that procedures and complexity.
You touch on one of our big issues we see with a lot of these kids. It's the fact that Medicare may be nationwide, but Medicaid is not. And so there have been more than one child where we've had to transfer or accept and transfer to establish Medicaid locally so that they can get the services at home.
Absolutely. We have to, a lot of times, first try see if we can transfer the patient to that state tertiary center and have to have an accepting facility. At the same time, brings up that question, is the child stable for the transfer? Is this, where would they get the best care? And only if they need to stay here, then start that single case agreement discussion. It helped that it was, this kid had Medicaid, but it was through the commercial payer, state Medicaid. So it was a lot more collaborative approach, and we were able to meet with their medical director team, with their care management team, and the administrative team, along with our and their contracting team, to come up with a common conclusion.
You see, and I don't know, when you talk about Medicaid, you end up with issues individually from state to state. But like in Georgia, Medicaid tends to not keep many on their roster. They tend to send them right to the CMOs. And each CMO has multiple states they work with. And so you find that can be an advantage when you know that. For some of our payers, we can actually work with multiple states because they already have arrangements in those states, and vice versa. It gets more complicated depending on the state you work with and how they do it. The other problem we frequently encounter is you want them stable for transfer, but the insurance company thinks if they're stable for transfer, they need to go home. And so you end up in a catch-22 because you can't send them home because you can't get the DME for whatever state you're sending them to. But they need to go home because it's time. And so you've got to negotiate that component. So a lot of these kids, particularly as they get more complicated, we have to start working much more aggressively to try to transfer them even before they're completely stable, so that they're not staying beyond the allowed time. That we're not transferring them to another hospital for them to deal with the fact the kid's stable. Why didn't they go?
Yeah, I think that was a great case to kind of bring up the complexity for these chronic long-term kids. And then I think with the payers as well. So thank you, Kimberly, for bringing the case today.
Yeah, and thanks for the discussion, Dr. Eanes and Kimberly. It was super helpful to learn more about the pediatric cases and get your perspective. And I really it's almost like the phrase that it's almost like a guessing game, which kid will recover and which kid will stay.
You see that all the time, unfortunately, in our business.
So true.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more.
Another interesting case to share. So we got this outside hospital transfer from, and again, we are closer to the border of another state. And so this kid came in with viral myocarditis. So to begin with, viral myocarditis, it's viral, it's more likely going to be reversible. But at the time of transfer, the reason for transfer is high level care that this kid needed because of heart failure from that viral myocarditis requiring ECMO and then heart support, and to the point where it was like, would this kid be even surviving or not? So the reason to discuss this case is, one, it's an outside hospital transfer where you as a tertiary care center are able to provide this high intensity care, but at the same time, it's from an state with an insurance plan that does not cover your hospital. So before I go any further, do you have any questions?
Just for me, when I hear that, because I get this question from my adult patients, from our transfer center, should we take this patient? We're out of network. And I that did catch my ear, and because oftentimes we will say no, knowing there are in-network facilities that this patient could go to, and we are not the only option. So, but I know when you're a pediatric, quaternary center, sometimes you are the only option, the closest and safest option. So I don't know, Dr. Eanes, how do you handle that when you know you're going to take a patient that's out of network?
We do have a set up policy to actually kind of address a lot of this, where it goes through the medical directors of the various campuses to make sure we are the only option. The difficulty is, even in those cases, that there may not be any other options, or the complexity of the kids, what's going on, where the referral. You'll see with a lot of pediatric hospitals that they're much more regional, excluding borders than many adult facilities.
I think you brought up a very good point, Dr. Eanes, and a lot of these transfers, and especially when we looked at these outside hospital transfers, which are not, and we're not the covered hospital, the challenge we ran into is we don't know at the time of transfer if this patient or this kid is the services they need is appropriate or not. Because a lot of times what they need initially is transfer so we can evaluate and see if this patient would benefit from either the air splint or those rare treatment options, which truly are specialization of our providers. So not knowing that makes it a little bit challenging. And some of these workups are challenging to get done at the local hospitals, at the smaller hospitals, and then trusting those results or having that correlated results. So we do run into that challenge of knowing, okay, is our hospital only hospital that can provide the care? At the same time, the safety of the kid is at stake, right? We want to make sure they still get the care they need and expedited care.
This is particularly true for this is particularly true for a lot of this is particularly true for a lot of NICU cases. We have a lot of NICU kids coming in and out of our facility where they'll be transferred to us for suspected services. We'll have to evaluate and decide whether or not they need those services, and then send them back to originating hospital if they don't need additional medical care or only required certain procedures and stuff. So for us in particular, we're doing a lot of in and out hospital transfers from that perspective.
So I'm going to ask you a more of a system level question. Then do you have a reciprocal contract with those sending facilities that if we do not provide those specialized treatment, that they will be taking the kid back?
Yes. Almost all the hospitals within Georgia we've arranged that with. Surprisingly, one of our big ones is we don't have a lot of pediatric ophthalmologists. And because of that, we can't send the ophthalmologist on a round trip through every hospital in Georgia. So a lot of those kids will come into us, get the procedure done, and immediately turn around and go back to their receiving facility. And you'll have them, they'll be on vents, they'll be high flow, NIPPV, all those different services. So you're moving kids that are relatively sick that require the care, but there's nowhere else to get it or no easy way to get it to them.
I've heard that called hello and go.
I think
so. Send them in and get that really high level intervention that can't be offered anywhere else. And then, glad to see you, glad to support you, and boom, back to the place where all of your local resources are and support system, et cetera.
It makes it good from our standpoint because we don't have a lot of beds for the really critically ill. So we have those rotating beds where those kids, they are really hello and go because they'll come in for a couple hours, get the procedure. It's almost like a clinic appointment. The doc hits one right after another, and then out the door they head.
I am wondering, Sweta.
Go ahead, sorry.
Well, I was just going to go back to the case where we started here because I was curious, for me, I'm a little bit worried when you're describing this kid that this is kind of a tenuous kid, that you're not going to have a lot of time. Some of these other, eye procedures, for example, maybe the kid's more stable. You can sort it out with the insurance company, get their blessing. I'm hearing a kid being described, if they're cardiogenic shock, that you may not have enough time to sort out, is there another hospital that's closer? Sometimes trying to figure out what services can be offered at an in-network hospital, or if you're pretty sure there isn't one, getting the insurance company to give you an upfront blessing before you take the patient, I think can be challenging. So I'm wondering if you actually had time on this particular kid to do some of the sorting out that we've just talked about.
You're spot on. We did not.
Okay.
So a lot of this one was more of a tenuous situation where it's an ICU level transfer for a kid who's in cardiogenic shock. We don't have time to sort out the insurance, or is there alternative? And we want to do the right thing for the kid and provide the best level of care, which we know we could, and so we did accept the transfer. This kid was in ICU for a very long time, got the support, the treatment, and once stabilized was moved to the floor, but still continued to require high level of care, which our floor level of care when we reached out, and I think that's where my next question was for rest of you, what would you do if the sending facility still doesn't feel comfortable now taking back, even though we don't have that specialized, the thing they were looking for or we were looking for, but they're still overall, the level of care that they need is above their comfort zone, or they say, hey, we now gave that bed away to another kid, so we don't have capacity to take this kid back. And you're still providing care. In this case, this kid was still, even on the floor, the level of care we were providing, I don't think we were too surprised to not being able to send back. I think it was best interest for patient to stay. But sometimes we run into cases where they are stable enough, where they're not ready for home discharge, but they still need to be in hospital, which can be taken care at the local hospital. But then local hospital don't feel comfortable taking them back. Have you run into those issues?
That's actually a regular issue as well from our standpoint. And there's a lot of contractual things that's arranged. There's a lot of negotiation. There's plenty of kids that sit with us and then we call the local hospital and have to work through what bed space they have, whether or not they're comfortable, what the situation is. Even the payers can be difficult because the payers don't understand the concept of going down from a higher level of care to a lower level of care. So for these kids, as soon as you're starting to think that direction, we start, our system starts working on talking to the payer and saying, hey, look, we'd like to do this. Can we do it? There have been plenty of kids that we have everything arranged and the payer says no, because you are the higher level of care. We're not sending back. So we have to work through all those details when we deal with these kids.
Yeah, I think that's where a lot of the good communication and continued communication at the same time efforts and the discussions definitely help. So in case of this kid was on the floor for a short period, but then again declined, developed a new bleed, went back to the ICU requiring high level of care again. And so again, not safe and still not completely out of the risk or safe enough for being out of the hospital. And it's now 3 to 4 months into the hospital stay. So this was the time now that we have used a lot of high intensity services as well as have had continued conversations. So it was a time to start having a more multidisciplinary approach and meeting and a more regular meeting. So we reached out to the peer provider team as well and had reached out for a collaborative meeting with the primary team, case management team, contracting team, similarly from the peer side, peer provider team, peer-to-peer team, as well as their contracting team and their complex case manager team. Before I go into further what was discussed, I think overall our experience so far was pretty good. They were pretty responsive. I think good learning lessons for me were the questions that were asked. One, which we've already talked about, why did this kid needed to be here compared to other hospital, and what level of care we were providing, and what do we anticipate the length of stay to be and the future treatment and disposition seem to be, so that they could have their team start working on supporting early on. I think the other question they asked, which was a very valid question, was how involved the family is and the support from the family, which I think makes sense, especially because this kid would not just continue to require care in the hospital, but even at the time of discharge, with every system involved, is not going to be right away running around. So would need high level of care even when ready for discharge. Any questions so far? Any other thoughts?
Just thinking about what you were talking about regarding the sending hospitals' reluctance sometimes to receive back because of concern for the continued acuity of the patient. Have you seen, or do your organization support your consultants having virtual privileges at the hospitals that are in your sending network, such that, you know, the stabilizing care can happen there and you can still have that oversight of your patient even when they're back in their usual environment?
I think that's a very good question. We do have where we are expanding our partnership with the other hospitals in the state and having some of our consultants be going there on a regular basis. Having said that, it's not still pretty well developed process for a virtual visit, or whenever possible, it's we try have our providers be enrolled with that pair product, or sometimes it's more of, oh, your provider is not enrolled, your facility is. So we run into those too. So looking into that more timely so that we are not chasing these things after the effect, but during their stay, having partnership with the business office has been super helpful. So overall, this kid eventually was moving in right direction, heart recovered, and was able to be safely discharged home. But I think for me, the good learning lesson was this collaboration and early on discussions starting so that they're aware with these high intensity, high charges cases, so that, like I think Kimberly, you brought up too, is involving them early on so they're aware of the challenges we are facing, can see in real time the complexity of the care. Because some of times showing these upfront are much easier than retrospectively after they have recovered and look so good on paper now.
Yeah, I think you hit the nail on the head. It's day to day that we're seeing that type of situation, and it certainly requires orchestration.
Yeah. Thanks again for the great discussion and sharing your valuable input. It's good to hear that every one of us, especially in the pediatric hospital side, are facing the same challenges. And especially when we have patients coming to the tertiary or the quaternary level care.
Absolutely. Thank you all.
Thank you to everyone for joining us for another episode of Case by Case. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so that you are notified when we upload new episodes. Until next time, this was Care Transitions Today, Case by Case.